start. I think we're 1 minute past start time, so I'll just take us through, and we'll pick up. We'll wait for others to trickle in as the conversation starts, so they can always catch up with us, and we'll share whatever comes out of this. But to kick us off, good morning, good afternoon, and good evening to everyone joining us from different parts of the world. Well, thank you for joining us on this Saturday morning, afternoon, evening. And thank you for joining us for this inaugural conversation with the Ugandan diaspora on the Global Cancer Financing platform. And for many of us in the diaspora, sending money back home is something that we do regularly. We send money to support our families, to help with school fees, to respond to emergencies. And very often we help when a loved one is sick. But in many cases, when illness strikes, families reach out and we respond quickly. We use systems, applications, and financial platforms that we trust will deliver that money safely to our relatives. But very often, we do not have visibility into how these systems are designed, how funds flow once they arrive, or how they might be structured to support healthcare in a more coordinated and impactful way. Still, today's conversation is an opportunity to begin changing that. Before we go further, it is important to first recognize the significant role that the diaspora plays in supporting families in the national economy. And according to the government sources, the net remittances to Uganda in the financial year 2024 were estimated at approximately $1.4 billion. So these contributions represent an important lifeline for many households and a meaningful component of Uganda's broader economic ecosystem. So these numbers reflect something important. One, the diaspora is already a major contributor to the Uganda's well-being. But there's also an opportunity to explore how these contributions can be supported by systems that are more structured, transparent, and aligned with specific healthcare needs. So this town hall brings the diaspora into the very early stages of thinking about how a platform can be designed to help support cancer care for our families and communities back home in a way that is transparent, trusted, and measurable. In other words, rather than simply responding to emergencies at a time, we have this opportunity to explore how systems can be designed to allow us as diaspora to allow the contributions we make to support cancer care more effectively and sustainably. So today we are honored to hear from several partners involved in this work. We will hear from colleagues at the Global Health Catalyst who have been helping convene global partners and strengthening cancer care. We'll hear from representatives from the Global Cancer Financing Platform who are working on innovative approaches to financing cancer treatment and care. We'll also hear from experts from the Uganda Cancer Institute who are the center of delivering care in Uganda. And of course, we're honored to welcome remarks from Her Excellency Ambassador Robie Kakonge, who continues to play an important role in bringing together stakeholders from across Uganda and the United States. Most importantly, today's conversation is about you, the diaspora. Your experiences, your insights, your ideas are critical. Many of you have supported relatives through difficult health journeys. Many of us work in healthcare, finance, technology, and other fields that can help shape solutions that are practical and effective. So I encourage you all to use this opportunity to share your perspectives, ask questions, yes, the difficult questions, contribute ideas as we begin thinking about how such a platform could be designed. If we do this well, together we can help build a system that not only supports our loved ones when they're sick, but also strengthens cancer care for families across Uganda and globally. This is just a pilot for Uganda, but this process is open to countries globally, and that will be represented by the many people who are joining us from other parts of the world. But it is therefore my great honor to introduce our very first speaker this afternoon, Her Excellency Ambassador Robie Kakonge. who is the ambassador of the Republic of Uganda to the US. She's played an important leadership role in bringing our partners together. And Your Excellency, thank you for the leadership and for helping convene this conversation and for bringing us here today. The floor is yours.
Vivian, I just want to first and foremost say thank you so much for this opportunity to engage with our community. And my humble request is that I will not be able to do the video, but if you just allow me, I'll not be able to do the video at the moment. Um, what I will do though, uh, sorry, I will not be able to do the video the full time, but what I can do is to at least turn it on for a minute and say a quick hello to everyone and to welcome you. So I just want to say a quick hello. Hi everyone, how are you?
Hi, Ambassador. We can see you.
Okay, great. I just had to at least put it if to match the face with the name. And then I want to get to the point of this discussion in that to welcome the diaspora. And I'm going to, usually I prefer a conversation, but because this is of great importance and it is official, allow me to read my statement. So I want to welcome everybody to the inaugural Diaspora Dialogue on the Global Cancer Financing Platform. Distinguished members of the Ugandan diaspora, colleagues, partners, and friends, good morning, good afternoon, and good evening to all of you joining us from across the United States and beyond. It's my pleasure to welcome you to this inaugural Diaspora Dialogue on the Global Cancer Financing Platform. Today's conversation reflects an important step in strengthening the partnership between Uganda and its diaspora community, particularly as we address one of the most pressing health challenges of our time, cancer. Before discussing the Global Cancer Financing Platform, it is important to recognize the strength and the significance of the Ugandan diaspora. Globally, estimates of the Ugandan diaspora vary. Some reports suggest that as many as 4 million Ugandans live outside the country, while official estimates place the number between approximately 781,000 to 1.35 million immigrants worldwide. What is clear is that the Ugandan diaspora represents a vibrant global community that continues to contribute significantly to Uganda's development. Ugandans based abroad are present across many regions, with major communities in Kenya, South Sudan, the United Kingdom, the United States, and countries in the Middle East. These communities contribute not only through cultural ties and professional expertise, but also through economic engagement and investment. Here in the United States, current estimates suggest that between 30,000 and 33,000 Ugandans reside across the country. The diaspora community is widely distributed with strong concentrations in states such as Massachusetts, California, Georgia, Maryland, and New York. Massachusetts also is estimated to host more than 4,000 Ugandans, many residing in Middlesex County. These communities are embedded in some of the world's most dynamic centers of innovation, medicine, finance, and technology. Equally significant is the economic contribution of the diaspora to Uganda's economy. According to estimates from State House, net remittances to Uganda in the financial year 2024 were approximately 1.42 billion US dollars. These remittances support families, education, housing, and healthcare, and they provide a vital lifeline for many households. In fact, these remittances exceed foreign direct investment. But beyond remittances lies an even greater opportunity. The diaspora is not only a source of financial support for families, The diaspora represents an important partner in Uganda's long-term economic development. This includes opportunities to mobilize investment, share expertise, and support innovation in key sectors such as healthcare. And this brings us to the challenge that has brought us together today. Cancer is a growing public health challenge in Uganda and across the African continent. According to data from the Uganda Cancer Institute and National Cancer Registries, Uganda records more than 34,000 new cancer cases each year, and nearly 23 Ugandans lose their lives to cancer annually. Beyond the human cost, cancer also places a heavy economic burden on families and communities. Treatment often requires repeated travel to specialized facilities, long hospital stays, medication costs, and loss of income for both patients and caregivers. For many families, a cancer diagnosis can quickly become a financial crisis. In many cases, diaspora members step in to provide the support needed to access treatment. When a loved one becomes ill, it's often the diaspora who mobilize resources quickly to help their families receive care. While these individual acts of support are powerful and deeply meaningful, they also highlight an opportunity. What if these contributions could be supported by systems that are more structured, transparent, and capable of strengthening cancer care for the entire country? This question has guided a series of important conversations over the past year as Uganda has begun exploring innovative approaches to financing cancer care through the Global Cancer Financing Platform. Our journey began with an initial dialogue involving the Permanent Secretary and Secretary to the Treasurer at the Ministry of Finance, who joined global partners to discuss the role of innovative financing in strengthening Uganda's cancer infrastructure. This conversation continued at the Global Health Catalyst Summit, where global health leaders gathered to explore practical solutions for strengthening cancer care in low and middle income countries. Further discussions took place during the Bloomberg New Economy engagement in Bunga, where Uganda's priorities were shared with global and policy stakeholders interested in sustainable health financing. Building on these discussions, we convened a scoping workshop in Uganda in December 2025 that brought together key national institutions, including the Uganda Cancer Institute, the Ministry of Finance, the Bank of Uganda, the Ministry of Health, and the Ministry of Foreign Affairs, along the global partners. In January, we continued this engagement where in Washington, D.C., convening stakeholders across government, academia, global health institutions, and the private sector to further explore partnerships that can support sustainable cancer care financing. Today, we reach another important milestone, the first dedicated conversation with the Ugandan diaspora on this initiative. This conversation recognizes a simple but powerful truth. The diaspora is already playing a vital role in supporting families facing illness. But the diaspora also has the potential to become strategic partners in shaping sustainable healthcare systems. Through the Global Cancer Financing Platform pilot, Uganda is exploring ways to bring together government leadership, global expertise, private sector innovation, and diaspora engagement to build sustainable systems for cancer prevention, diagnosis, treatment, and research. Today's town hall provides an opportunity for the diaspora to contribute ideas, perspectives, and insights at the early stages of this process. It allows us to begin thinking together about how diaspora contributions can move beyond individual emergency responses to become part of a coordinated system that strengthens cancer care for families across Uganda. In other words, today's conversation is about building a foundation for systems that are transparent, trusted, and capable of delivering measurable impact for patients and families. A foundation that brings together Ugandans at home and abroad to address one of the most important health challenges of our generation. I thank you all for joining us today and for your continued commitment to Uganda. Together, we have the opportunity to transform compassion into systems and individual support into sustainable solutions that will benefit generations to come. Thank you so much for this opportunity, and I look forward to an engaging conversation and a successful journey. Thank you.
Thank you very much, Your Excellency, for those thoughtful remarks and for highlighting both the opportunity and the responsibility that comes with diaspora engagement in strengthening health systems in Uganda. And as the ambassador has outlined, this initiative has evolved through a series of important collaborations between national institutions and global partners. One of the organizations that has played a key role in bringing these conversations together is the Global Health Catalyst. So the Global Health Catalyst has been instrumental in convening leaders across medicine, policy, innovation, academia to address complex health challenges such as cancer, particularly in low and middle income countries. To help us understand the broader vision behind these collaborations and how they connect to the work we're discussing today, it's my pleasure to invite one of the directors he's the founding director of the Global Health Catalyst, Dr. Wil Ngwa, to share a few remarks. But before he does, I just wanted to, I guess we'll let him share his remarks first, and then we'll take it from there.
Thank you so much, Vivian. Yeah, this is, I always want to say, thank you so much, Ambassador, for your leadership in making this happen. As Vivian said, we definitely are not thinking only about Uganda, but we have to say the leadership of your leadership and that of Dr. Orem Jackson and the Ugandan government, has really been an inspiration. And really we want to thank you for your leadership in doing that. So I'm going to talk a little bit about, Ambassador already talked about the progress that has been made so far. I actually want to take a step back to the White House because I know that's when Dr. Catharine, who is going to talk a little bit afterwards, when the whole idea of creating a global cancer fund really began to take shape. Prior to that, we actually published a paper inspired by some of the work from Catharine in the White House. Dr. Orem Jackson and we published a paper about extending the cancer moonshot to Africa back in 2022, which seemed at that time quite abstract, but it's really wonderful to see the progress that's been made to get to where we are today. And so, obviously ambassadors talk about the history from where things have evolved from the White House to the Global Health Catalyst Summits. And we are just not the only organization involved. Obviously there are over 50 organizations that are part of this global cancer financing platform. I think Catharine will talk about that. But things really over the past year have really taken, like Ambassador said, a lot of action. And we're very, very excited and honored that we're able to go to Uganda, where we visited. Dr. Orem hosted us together with the government. And then just in February, we had this embassy meeting in Washington, D.C. And so, this is another step in that direction. And I think today is actually historic because we get to actually really engage with the diaspora, especially beginning with Uganda, to get their input and help and assistance in helping shape this initiative. Ambassador talked about this for Uganda, but I just want to tell you why this is so urgent for us to act, right? So cancer, they used to say it was a disease for the rich people, for the high income countries. They're the ones who are being cured. But if you actually look at the data, you see that low and mid income countries are now, really the epicenter of this pandemic. We can call it a pandemic. It's not the right word necessarily, but it's to show you that this is more than COVID, right? It's killing more people than COVID-19 did. 10 million people a year. And as Ambassador said, the economic toll is actually trillions of dollars. Now, if you look at this map, you see that the red is mostly Africa. And that's because the access to care is a problem. You can see Uganda is part of that red, which means that we are really, what we are doing today, the impact can really be big. It can really be huge. And I also want to show this picture, as you may hear why the focus partly is on, downstaging cancer. when we did the Lancet Oncology Commission for Sub-Saharan Africa, one of the key things that came out is obviously in Africa, people are being killed. Leading cancer, death is cervical cancer, breast cancer. These are the three top cancers: prostate, cervical, breast. But one of the things that was really, that stood out really well was that most of these people who are dying with cancer present late with the disease, and especially women. And so this is something that the Global Cancer Financing Platform has come together to say, well, one of the first priorities will be to kind of look at this to downstage cancer, so you can catch it early and can cure. So ambassadors say, what if, I actually really like this quote from Einstein, which said, imagination is more important than knowledge. And so growing up in Africa myself, I say I grew up in Wakanda, say Uganda, but I remember times when I would cry, just thinking about why is it that just because I'm born in this particular country or location that I don't have access to the same care that you would have in Boston or Harvard or other places. And then when the Wakanda movie came out, kind of thought, wow, Wakanda is in Africa. It's a city where people come there and can get a country where you come there and get care. Everybody has access to the best care. What about a future like that? And I think the diaspora is actually Africa's secret Wakanda power. You could really help drive, a future where people can have access to care. And that's really grounded in some of these opportunities that we present today, talking about remittances. So if you look at the World Bank data, you can see over $685 billion per year in remittances. Obviously, Africa, about right up there, 56 billion. And so if you can just tap just 1% of this, directed more purposefully, like Ambassador says, structure that towards healthcare systems or cancer, the impact of that will be huge. And I know a lot of people who want to do this. So quickly, just in the last, points I want to make, just say there are two powerful opportunities that, over the past year have emerged. One is the idea of diaspora bonds, which are really like investments that you do, and you can actually get a return on that investment, major investments. But there's another instrument that you can use, and I know later on during the Q&A, Chris Muflam can answer more questions around this. But the idea of vouchers, which is really like what are you already doing right now, but you just channel that through a different financial rail that goes towards it's more purposeful and structured, and you can be able to track the impact of your work. And that can also create catalytic capital for other investments, including from what we call that global allies. So while we focus on diaspora today, we actually have a number of faith-based organizations. We have a number of philanthropic organizations who are interested in investing through this platform. But obviously diaspora, we have that shared interest because some of us are from Uganda, some are from other countries, and we want to see those countries succeed. We're more passionate. So this picture kind of captures, the whole idea of having a global cancer financing platform. The diaspora is there, but you can have faith-based organizations, philanthropy, impact investors. You can all participate in this. Diaspora bonds are one way, one instrument, one of the tools where you can get return on your investment. Health vouchers are ways that we can probably start. That's lower hanging fruit. But all of this can really, I think what has really changed today that makes this more possible, we call this enabling technologies, is the availability of things like blockchain, where I know most diaspora would say trust and accountability is a huge issue, why they don't want to send their money to this kind of uses. But you can actually track your money through blockchain technology now in a transparent system through this financing platform. We have AI that can help, generate the data that can help guide how the money is implemented, how this is implemented. And so that full transparency and accountability means that we now have a really tremendous opportunity where, all of us can really participate without that concern. So last, I would like to point out that, think about this global cancer financing platform like Wall Street. So this is a kind of great picture that Chris Muflam has captured. Where you can go on there, you can see. We're starting with Uganda, but you could think about Nigeria, you could think about Bangladesh, you could think about South America, right? We can go on that platform. You can see, what are the key performance, what are the needs that people want, and you can pick your stock. Essentially, you can pick where you want to channel your money, and then you can watch in real time where your money, when it's spent, and what the impact is having. And that's really the future. That's what this financing platform looks like. And I'm going to end with this slide that basically tells you how your money would move. Okay, so if you think about your $100 that you want to put on this platform, what's the journey from that to Uganda Cancer Institute? So you sit in Boston, where most of the Uganda diaspora in Massachusetts are, like Ambassador said. You get on your computer, you can log in, you can put your $100. It goes through this platform, blockchain, transparency, and AI accountability, and it goes to a special purpose vehicle bank in Uganda, which has already been identified. The Ministry of Finance is a partner in this and overseen by the Bank of Uganda. So regulatory-wise, that's the great reason why we had this partnership with the Ministry of Finance, right? And then the money sits there, and then Dr. Jackson, basically, who leads the Uganda Cancer Institute, has already identified what are the key performance indicators or the milestones or things what are the needs. And so that money can be released to the Uganda Cancer Institute for that particular purpose and to meet that need. And then, so Sarah, who is the cancer patient who needs that downstaging her cancer, comes in there and gets screened. And so can get their treatment and their life can be saved. They don't have to catch the cancer late. But more importantly, you can also have that transparency. So once that's done, you can go back to your Wall Street financing platform, and you can see, you get a report back, on how that money has helped Sarah, which could be a family member, but also the impact that it has had. And then because you're actually pooling this money with other people, that your money can actually go further. So this is a good way that you could probably picture this platform. All right. So I just want to end by saying that, there's a lot of tremendous support around this. Talking to Catharine, we're actually looking at how we can engage the United States State Department as well, because they're already having agreements between the United States and Uganda, for example, but, working together with the diaspora, that can even go further. And so this platform, we are planning to launch this in Uganda this summer. So, today's conversation is really important to be able to engage and hear from the diaspora. Thank you so much.
Thank you so much, Dr. Wil Ngwa, one of the visionaries who has enabled these catalytic collaborations to happen. With that said, I would like to move, as we move further into our conversation today, we now turn to the core initiative that has brought us together, the Global Cancer Financing Platform. So this platform is, of course, as everybody has stated, is exploring innovative ways to mobilize sustainable financing for cancer care by bringing together governments and all the stakeholders. So to walk us through the thinking behind the platform, and it is my pleasure to invite the lead for the Global Cancer Financing Platform, Dr. Catharine Young, who started these conversations when she still worked with the White House under the Biden administration. Over to you, Dr. Young.
Thank you so much, Vivian, and a big welcome to all of you who have joined today. Thank you for sharing your very valuable Saturday time with us, and also a big thank you to Wil and the ambassador for really setting such an amazing foundation of this work already. So I will go right into it and just quickly share some slides. Okay. Can you see that okay, Vivian? Let me just...
Yes.
Okay, perfect. Okay. As Will and Vivian have both mentioned, this work really began at the end of the administration in 2024. My previous role was working at the Biden Cancer Moonshot, which was a White House initiative that was historically a domestic focused initiative, but evolved over time to think about how we can really bring countries together to make an impactful difference in the lives of cancer patients around the world. At the end of the administration, we started to think about what is that one thing, if we were able to accomplish, would make catalytic change in the lives of cancer patients, particularly in low and middle income countries. And the one thing that kept on raising to the surface was the idea of a global cancer fund. Now, this idea is not a new one. It has been around in the global cancer community for well over a decade, but we absolutely understand that the time is now, and it's never been more urgent for us to be able to execute on this. Now, one of the reasons why it is so important is because we can look at the current state of global health funding. These numbers represent the changes that have occurred in just this past year alone. There's been a 21% reduction in development assistance for health globally. So we've gone from about 50 billion down to about 40 billion. Now, within that, if we look at the sub-Saharan Africa region as a whole, that decline has been about 25%. So a quarter of funding for global health to sub-Saharan Africa has now been reduced. And interestingly, it has not only been a reduction or contraction from the United States, although that has been massive. We've seen a 67% reduction in this past year in terms of the US contributions to global health funding, but it has also rippled to other wealthy countries, including the UK, France, and Germany as well. So this has now become a really collective problem that we are facing. And more starkingly is the stat of 299 times greater health spending in high income countries when we compare that to low income countries in 2025, so last year alone. And forecasts show that these disparities will only increase in time over the next 5 years. So it is absolutely urgent that we fill this financing gap. Now, when we think about the state of global cancer funding, when we think of the global health funding cuts that have occurred already, it's important to keep in mind that in the totality of those global health figures, less than 5% target cancer and other non-communicable diseases. That is just a sliver of the funding that is provided for global health funding. Now, we contrast that to the fact that over 70% of cancer deaths occur in low and middle income countries, and we can see this really stark contradiction of the amount of funding that's going towards cancer versus the deaths that are occurring around the world because of it. And interestingly, we can look at amazing examples of what happens when we have a very dedicated financing mechanism behind different disease states. So many of you may be aware of the Global Fund, which was created about 2 decades ago. It focuses on HIV, tuberculosis, and malaria, and it has been incredibly successful, saving about 70 million lives since its inception. Now, if you compare that to cancer, cancer causes more deaths than HIV, TB, and malaria combined, and yet we still don't have a dedicated financing mechanism for this. And because most cases are diagnosed too late for effective treatment, this is an important point as we go into the overall goals of the global cancer financing platform as well. And we know that without new financing models, without injecting the sense of urgency into creating new financing mechanisms for cancer, the global cancer burden will nearly double by 2050. So, this past September was the official launch of the Global Cancer Financing Platform in New York City that was co-hosted by the Bloomberg New Economy and ASCO, and it brought together stakeholders from across the globe. And it was at this event that we announced several things about the Global Cancer Financing Platform in terms of its overarching goals. And I want to share this with everyone because I think this is really important to set in terms of what it is that we're trying to achieve with this work. The first goal is to mobilize 1 billion by 2030. But as many of you have heard me say already, this is the conservative goal. The ambitious goal is to mobilize at least $1 billion by 2030, and for that to be sustainable year after year. So this is not meant to be a one-time fundraise and then we retract backwards. This is meant to be a sustainable financial flow into low and middle income countries year after year. Now, the first 8 to 10 months of this work actually involved a lot of consensus building with the global cancer community in terms of what the focus of this work will start out to be. Now, imagine potentially why this work hasn't actually been done before over the last decade. Partly because cancer is an incredibly complex disease made up of not just one, but over 200 diseases. And the components that are required from prevention all the way through palliative care are enormous. So coming to consensus on what this focus should be was a large part of the work prior to our announcement at UNGA in September. And where we have landed is the focus on stage shifting. So as Wil and the ambassador has mentioned before, this is the idea of catching cancer earlier and moving stage 3 and 4 diagnoses to a stage 1 and 2. This does two things for us. One is it provides the patient the greatest opportunity to reach their full potential after diagnosis. And the second is it actually reduces the burden on the healthcare system. So it is a win-win situation here for both the patient and the quality of their life, as well as the healthcare system at large. Now, if we take this one step further, we also came to consensus in terms of launching first with breast and cervical cancers. Now, the reason we came to this conclusion is because there are so many global frameworks that already exist, particularly with the future elimination of cervical cancer itself. But also we can think of it in terms of the infrastructure that has already been built around cancers like cervical cancer through massive initiatives like PEPFAR and the Global Fund. So it's really important that we don't come in here and just blaze new trails, but instead we come in and we provide the support and amplification and utilize the foundational infrastructure that has been already created to really push this work forward. Now, many of you may be asking, well, you've just gone through a slide showing really a very dire global health and global cancer financing environment. How on earth will you reach this ambitious goal of mobilizing 1 billion per year by 2030? And the way that we do this is to unlock new capital from previously untapped money. And this is really why we are all here today. And Wil really laid this out so well before, and the ambassador touched on this as well. But I want to just make these points very clear. The diaspora community as a whole holds an enormous amount of power. In fact, it sends over 650 billion in remittances around the world every single year. And in many countries, diaspora flows exceed foreign aid and development assistance. That is how powerful this community is. And as Vivian mentioned in her remarks up front, diaspora capital is already deeply connected to national development as well as healthcare assistance. And so we can immediately think of the diaspora as a powerful partner in building health systems and in saving lives as well. Now, the ambassador mentioned this number before. Uganda receives about 1.3 to about 2 billion in remittances annually. And I want to put it in perspective here. That represents roughly 4% of Uganda's GDP. That is an enormous amount of capital flow. And to make a comparison to what Uganda spends on infrastructure in their country as a whole, so we can think about transportation systems and roadworks and the energy grid, Uganda spends about 1 billion annually on that collectively. So we can see the immense potential that the diaspora remittances brings to this work. And this is what I mean by tapping into money that hasn't necessarily been focused on this particular type of work before. Now, Will went into a little bit of detail about the Uganda pilot that we are executing, and I just want to take one step above, kind of give a higher level indication of this work. There are really two goals to this work. The first is to unlock the power of the diaspora, as I just mentioned, to tap into not only that flow of money, but also the motivation to invest into the country when it comes to healthcare infrastructure. But the second goal is also to pressure test a new financing model that treats cancer like infrastructure. So when you think about where will your money go to, this is what it will be going towards. Now, as the other speakers have mentioned before, this work is well underway, and we've had 2 in-person meetings already back in December, an in-country meeting bringing together the Uganda government across different sectors from finance and health. And then just recently in January, hosted by the ambassador, an event that brought together different stakeholders to start getting input on this work as well. Now, why do I say infrastructure? And this is my last slide, but I want to make this very clear because it's a very important part of this work is really thinking about how we treat cancer control and cancer care in countries. We have to think about cancer control because it requires systems. It doesn't just require program. It doesn't necessarily work when we come in with funding that is funding siloed projects that often, are great for certain aspects, but don't really solve the system as a whole. And you can think of screening networks, diagnostics, surgery, radiotherapy, all of these big components as national healthcare infrastructure. And just like our roads and our power grids, these systems require upfront capital investment. And this is where the diaspora comes into. Now, also early detection, so catching cancers earlier and being able to provide them treatment that prolongs their life as long as possible, deliver immense long-term economic returns as well. So the opportunity here is really clear that we need to develop new finance cancer systems, and we need to be able to think about this in the way that we finance infrastructure in our countries as well. And with that, I just want to say a big thank you. This work, as Will has mentioned before, really is only possible because of collaborations with many, many, many organizations. And here are just a few that have made this work possible up until this point. So thank you so much for your time. I will stop there. And Vivian, I will turn it back to you.
Dr. Young, it's always great to hear you speak, to hear you share this vision that we're bringing to life. And in that context, so thank you for the work that you do. In that context, I wanted to, before we pivot to the next speaker, to take a moment to introduce a few. So some of these, we're here because of some weekly meetings that happen with so many people behind the scenes. Just to very briefly introduce to you a team from the Global Health Catalyst, and also if Kamal is here, that would be great. Starting with Dr. Seifel, Dr. Avery, if you would kindly say hello to the people, introduce yourselves so that people, especially the ambassador, can put a face to some of these names.
Thank you, Vivian. It's really an honor to be part of this initiative. As you say, we meet pretty much every week to talk about this. And, both the ambassador and the honorable ambassador, Catharine and Will, have really articulated very well as to why we are in this. And as Catherine pointed out, the PEPFAR program, that saved millions and millions of people. And that inspires me that, we are in a situation where all of us together in a government, all of us in the diaspora, we all can contribute to this major initiative. And looking ahead, 5, 10 years from today, if we look back today, the initiative that we took today, and will be really telling that we have been part of a major initiative which helped in saving, hundreds of thousands of lives. And there can be nothing better, nothing more rewarding than this. So it's really an honor to be part of this initiative. Thank you, Vivian.
But Dr. Saifo, you didn't introduce yourself. Like, what do you do?
Okay. Thank you. So I'm a medical physicist, and at the University of Pittsburgh here, I'm a professor of radiation oncology at the University of Pittsburgh and director of medical physics at UPMC Hillman Cancer Center. And I'm also one of the directors of Global Health Catalyst.
And now recently vice president for Armstrong. But okay. He's very humble, but yeah, Dr. Saifo, thank you so much for introducing yourself. He's one of the directors of the Global Health Catalyst. Dr. Avery?
Yeah, good morning, good afternoon, everyone. Thank you, Ambassador Robbie, Global Health Catalyst, all the diaspora leaders joining us today. Stephen Avery, I'm from the University of Pennsylvania, I'm professor of radiation oncology, work as a medical physicist. I'm so happy to be part of this conversation today because it's so important, because global cancer disparities is not just a technology issue, it's a systems issue. And one of the most important pieces of that is people. Without trained physicians, physicists, nurses, that we cannot give, proper care. This is where the Ampere program comes in, and it's an NIH-supported initiative to help build the next generation that we talked about in Uganda. But the the Global Cancer Financing Platform is what is needed to connect that capital with the workforce development. And so I'm looking forward to more conversations today. Thank you.
Thank you, Dr. Avery. So there is also a bigger team for the Global Health Catalyst, and if we have time at the end, we might ask them to also introduce themselves, but in the interest of time, let's just head back into our speakers. So following Dr. Young, first of all, it's we're here because the Uganda Cancer Institute has taken the initiative to really lead us through this process in aligning the framework or the platform with goals or key performance indicators. So, and cancer financing is ultimately grounded in the realities of delivering this care to patients and families, and this is where the work of the UCI comes in. UCI stands at the center of cancer treatment, research, and training in Uganda. Every day, the teams work with patients and families facing very big challenges that we have been discussing today, that we discussed for quite a while. And what is not commonly said is how big the Uganda Cancer Institute is in terms of the work that they do. They are truly a center of excellence. And if you have a chance to visit the Uganda Cancer Institute, I can assure you that it stands out in the region. And I could go on, and we'll probably have updates about what the Uganda Cancer Institute is doing. But to help us understand the realities on the ground, including the growing demand for cancer services and opportunities to strengthen care systems, it is my honor to invite the director of the Uganda Cancer Institute to share his perspective with us, Dr. Orem Jackson. Over to you.
Thank you very much, Vivian, for that introduction. Let me just also start by, first of all, thanking the ambassador for a very elaborate background that she has given. And then, of course, I think both Catherine as well as Wil have given really the substance of the issue. Of course, from the side of the Uganda Cancer Institute, I really want to say we are really honored to have this conversation and also to engage with our citizens, as well as, of course, people who are very important in as far as trying to support relatives, friends who may be in need of assistance when it comes to health issues. And then, of course, cancer stands out among, some of the most devastating illnesses that very costly to manage within systems that in most cases are under resourced. And from that background, I want to really bring the reassurance of the commitment that the government of Uganda over so many years has actually done in as far as supporting cancer care is concerned. Of course, by just establishing the Uganda Cancer Institute is a really big plus for what our leadership has been doing over the years. And as you know, and I think Catherine mentioned this in her presentation, cancer has not been attracting resources that much in as far as trying to support healthcare. The government has tried its best, but most development partners do not usually really want to invest in the cancer space. And I think for obvious reason, it's quite expensive. And I think that is where now, trying to look for other mechanism of bringing resources comes in. And in this regard, really, I want to applaud the Global Health Catalyst together with the Global Financing Platform for taking the lead, in fact, leading the world actually, in as far as this new area is concerned. And we are so proud as Uganda and the Uganda Cancer Institute to be the guinea pig in as far as this is concerned. And I think we have really taken that with honor.
Dr.
For
Orem, I think accidentally your video was turned off, but just wanted to.
Oh, I think, yeah, no problem. Yeah. So in as far as our diaspora colleagues are concerned, my reassurance is that there is actually a good system being built by our government in as far as cancer management and control is concerned. And that is the whole essence of establishing the Uganda Cancer Institute. And our government has over the years been incrementally increasing financing for this, for putting up infrastructure, equipment, as well as development of human resource capacity. But this has actually been, to some extent, I would say, outpaced by the demand because we have been seeing incrementally huge numbers of people coming to get care. And in order to match this, actually, we have decided to fully implement our National Cancer Control Plan, which has been in development, but is also being implemented at the same time. And one of the key aspects of this, because of the increasing numbers, as well as, of course, the difficulty of reaching patients who, in most cases, are coming from the countryside or upcountry, as we call it here, we have decided now to begin decentralizing our services by creating what we call regional cancer centers. We are starting with 4 of them, and that means that there is going to be the Uganda Cancer Institute as we know it in Kampala, but with satellites in these regional cancer centers. We have one in the northwestern part of the country, Arua, one in Gulu, another one in the eastern part of the country, Mbale, and then another one in the western part of the country, in Barara. That means that all the corners of the countries will at least have a regional cancer center, and that will cut distance as well as the challenges of mobility to go and get treatment, which in most cases would have been in Kampala. And then, of course, with the use of technology, we are going to be linking all these centers to our system in Kampala. That means there is an aspect of ensuring that the quality of treatment, even if a patient is going to be getting the treatment from the regional cancer centers or from the periphery, the quality will be actually assured, given that the system is integrated. So that is one. Of course, the question is going to come, are all these centers now functional? As I speak now, I would say 2 are functional, but the others are still being constructed. Our government has already secured funding for actually all of them within the current National Development Plan. So that's number one point. There is a system that is being built, and that system is being kind of made to attain international standards. And in that aspect, we are also the designated East Africa Center of Excellence. That means there is something which we are doing which can actually be also copied by our region, so that, the best practices that is seen in Uganda can also be transferable to other parts of the region in Africa. And I think that also makes sense in as far as this initiative is concerned, because after piloting in Uganda, the next maybe in Kenya, they can also do the same, basing on the outcome from the Ugandan initiative. The number 2, which I think is very important, and the diaspora would also kind of play a big role in, is technology transfer as well as innovation. Of course, our diasporans, I think they are in various trade, and some of them maybe are also in health. And I think there's, in addition to just the funding, their connectivity with what's going on at home can actually also trigger other areas of technology transfer, because of what they have gone through and what they have possessed in as far as their being outside of the country in a different system is concerned. So that would actually be another advantage of the current system. And then, of course, thirdly, I would want to say that Uganda doesn't have a health insurance as of now, and the addition of innovative financing, and especially when it is targeting conditions like cancer, would actually be a huge leap forward in as far as financing for an area which is not usually attracting resources, and in a system which doesn't have a national health insurance. So I think the timing is very right in as far as we are concerned, because already this is going to be helping to support people who in most cases do not really have resources for managing a difficult condition. Finally, at the end of the day, I think this has also been touched on by both Catharine as well as Wil. What is very key is the outcome. After all this investment, there must be good outcome. And we are looking at making sure that at the end we improve both at the level of the individual as well as at the level of the community, the outcome of cancer, be it survival, be it good quality of life, name it. We want that to be something which can actually be tangibly observed after all this we have done. So in a nutshell, Uganda has a system in place. It has been improved over time. The government has put financing in as far as cancer care is concerned, but it needs additional push in order for it to produce the outcome that we would want to expect. And of course, once this is out, this can be shared with other members of the developing countries who will see what is happening in Uganda. And I think this is going to be a very important landmark in as far as health financing is concerned globally. Thank you.
Thank you, Dr. Orem, for always sharing the vision for the center and ways we can be a part of this vision. You have led the Institute with tremendous milestones. So thank you so much. And Dr. Orem has mentioned, Uganda has a system in place. So the question for all of us while we're here is, how do we tap into this system to build a financing platform that works for all? And I wanted maybe to point out that if you have any questions, so you don't forget them, throw them in the chat. There's going to be a Q&A session after the speakers are done. But if you have a question that you don't want to forget, just throw it in the chat and someone on the team is going to be monitoring the questions. So speaking of the platform, as we've heard, addressing these challenges requires, all this expertise, coordination, but to help bring these different pieces together, we have Chris Muflam, who is taking really the lead in shaping this platform. And so I would like to invite him to share more about what this platform would look like and how the diaspora, could participate or contribute to it. And as he's speaking, I'll request those who are going to speak on behalf of the diaspora to get ready, because you'll be speaking right after. And he's going to give us an overview, but then we will have lots of questions for him during the Q&A session. So over to you, Chris.
Okay, so thank you, Vivian. Thank you, everyone. I just want to take a moment and I'll answer your question. Permit me to answer your question in the pilot logic. It's really important to understand exactly that the pilot is structured in phases. So the reason is each stage needs to prove something that the next stage depends on. So phase one really is focused on a 21-day cycle. So it's a 21-day close that is basically proving that predefined rules for verifying clinical events, key performance indicators stay the same cycle after cycle and across onboarded facilities, right? So regarding exactly how they define the key performance indicator, how it's costed, how they do quality controls, and what goes into really saying, okay, out of all these outcomes, which one qualifies to be funded, right? So we get to prove that. And then we see that, okay, if you deliver this service, what's the cost? Does it make sense, right? Again and again, it has to make sense. And then eventually we want to say, okay, we're seeing that there is a trend. We don't want to overshoot spending. We've talked about cancer being expensive. We don't want to overshoot spending. So in this repetitive process, every 21 days, we are actually seeing exactly how the costs are narrowing down based on the rules that we have set. And then we also see that eventually we are getting ready to be able to activate an instrument that enables us to pay for that cancer service, right, in a way that it is structured. So what we are looking for is really prepare phase one to be voucher ready, right? So that when we actually activate the vouchers, the diaspora and global allies are confident about purchasing the vouchers for a defined service instead of sending cash the way they normally do now. So that is phase one. Phase two then proves that the pilot can really pay safely for a defined service, with vouchers under custody and verification. Then phase 3 then proves that the pilot can really build on the voucher redemptions in phase 2, right, to be able to scale that service responsibly, and so that basically the service is actually expanded to broader communities using broader capital such as bonds. I just wanted to give you the logic around how we are actually implementing the pilot. So one phase is building up, is proving something that the next phase depends on. So number one, we are actually in the trust building phase right now, which is phase 1. It's repetitive because we want to be able to really verify what it means when you talk of maybe breast cancer completed. Does the definition stay consistent across clinicians and across facilities, right? And want to make sure. So if you actually defined it as such, how much did you charge for that particular service, right? We want to make sure that it's repetitive. It's not a one-time measure. So we do that over time. We'll begin to see that there is a kind of a stabilization of the costs for that particular screening, which then informs the pricing of a voucher, which is then purchased by the diaspora and the global partners to be able to offer services to their families and the communities. And that track record is critical. It's like a credit history, which can now be underwritten to expand that particular breast screening service, using bonds, using even local banks can offer loans for working capital to a maintenance contractor, to a pharmacy which has been onboarded. All the providers have to be onboarded. So I just wanted to give you an overview of exactly how the pilot is operating. So I'll end there.
No, thank you so much for the big overview. And as we get into the next phase of the diaspora, I wanted us to maybe to prompt our diaspora on this call, or anyone who is attending this town hall, to think through a process where we want to provide support for treatment for a patient back home in Uganda. What would you want to see that platform doing for you or for us, so that that can help us think through what kind of platform we want? It's a financing platform. Oftentimes we send money through World Remit, name it, but it's not for a particular, to be used in a particular way. We can't track whether it's gone to a particular health service. But if there is this, not if, there is this vision to create a system where you can send money and direct where that money needs to go or what it needs to pay for. So as we think through that, how would you want that system to be designed? What guards would you want to have in place to make sure that your money is secure and you feel confident enough to use the system? So with that, first of all, thank you again, Chris. I would like to introduce us to, as we think through those questions for Chris, is to today's conversation. We've definitely had that diaspora is key. So we would like to invite, let me see, the first person is the UNAA president, Ettibot, Mr. Ettibot, to come and give us an overview of why the diaspora is important in an initiative like this one as stakeholders. So UNAA is the global, he will explain what it does, but it brings together all diaspora in North America. So Mr. Ettibot, Lambert, over to you.
Thank you so much, Vivian. Your Excellency, the Ambassador, Robie Kakonge, the Global Health Catalyst Team, Uganda Cancer Institute, and my fellow UNAA leaders, and all protocol observed, greetings to you all. My name is Lambert Ettibot. I am the president of the Uganda North American Association, UNAA. And I'm so glad we're having this discussion. I was privileged to be in Washington, D.C. with the team pretty much doing the presentation today. And we had a really detailed discussion, went through a few tests here and there of, how this is going to work. So I'm very confident that this is, first of all, a very good initiative that's going to be very, very good for our people back home, our friends and families. But also, we are very privileged that Uganda is the pilot country. So to my diaspora members, this is a challenge to you. We have to make this work so that other countries can take our example. But I think, Vivian, to the question that you asked, I think I had the chance to ask a lot of questions similar to that during our test. I have leaders within UNAA that are on this call. I know the vice president is here, and the executive secretary, director of communications, and some of the council members are all here. We have the rest of the diaspora leaders as well on the call. We'll give them a chance to do that. But it's always going to revolve around trust and accountability, okay, for the diaspora. And as long as those questions are answered, I think we will be okay. On my part as president, I want to offer the team a platform at our convention in Denver, okay? We're having a convention from September 3rd to the 7th. We'll give you another chance to share this. And let's continue to have these conversations, because for the diaspora, sensitization is going to be key. The more we understand the program, the more we participate. So we can't have you far away. We want you close, and so we always understand what's going on. I think that is very key. I would like to also say that we partnered with the UNAMS, which is Uganda North American Medical Society, a group of nurses and doctors here in North America, USA and Canada. They are doing a good job. Now we want to partner with you as well, okay? So that there is going to be continuous conversations. So with that said, Vivian, I would like to yield back to you, and I'll leave the rest of my team to ask questions during the Q&A. Thank you so much.
Thank you, Lambert, for first of all offering a platform for this work during the convention. We'll certainly be there with a force, and we're excited to have you as key stakeholders. And yes, I've seen Georgina on. I hope she will have questions very soon. With that, I want to pivot to the next diaspora member who was with us in Washington, D.C. That is Miss Brenda Katama. If you would kindly share your experience with us and why this matters and what could be done. Brenda?
Hi. Yes, I'm here, sorry. Running through different fields with soccer guys. Thank you so much, Vivian. For my background fancy setting. But can you hear me, Vivian?
Yes, I can. She's multitasking with a child at a soccer game.
Yes. Yes, here in Virginia, it's actually a little warm, so we're excited. But yeah, thank you, everybody, the ambassador and everybody else in your positions. Thank you so much for joining us. I really liked everything I heard. Vivian, thank you for making us be part of these conversations. And it makes us feel like we're part of it. And there's no any other way we can be part of it if we're not being part of it. So our conversations, our voices are being heard, and this is a big step. I appreciate that last time we were in DC, we talked about, like, some of us in the diaspora who were part of the diaspora team, Lambert and other guys who were there. We talked about sensitization, bringing in the diaspora in all the communication, all the way through in all the programs that you guys that you're trying to put forward. And you've gone ahead to do that, so this is great. This is already a thumbs up in making this happen. So I like the pilot mostly because being part of the diaspora, personal story, Both my parents actually had cancer. They both passed away different years, but my mom had colon cancer. It was late detected, so that's why I say this is a cause really close to my heart, because by the time we found out and I was living here, but I just saw her shrink and shrink. One time I was home, and I just saw her. She didn't look great, and I said, you know what, we have to go to Kampala. And that time, yes, Mbarara did not have, this is like the regional imbalance when it comes to healthcare. So I'm glad to hear Dr. Orem say that more facilities that are being in place, the government is other facilities in different regions. But we had to drive from Mbarara, come to Kampala. Sorry, guys. So we drove to Kampala, and it was by the time they did all the tests, she was already at stage 4. So as you can imagine, yes, the doctors told her she could not leave past 6 months. We were able to have her for 7 months. But yes, it's just ate her away. Almost all her stomach was gone. She did surgeries and all that. So did my dad. My dad had a different kind of cancer. I don't remember which one, but yes, the same story, late detection. So this is exciting in that if this bond goes in, or a bond, or I don't know how we're calling it, a diaspora voucher, if let's say some of my family calls me and says, Brenda, so-and-so has cancer, I will know that the money that I'm sending is going directly to that specific cause. And how will I know that? From the engagement we had in DC, people who were talking about it were like, hey, you'd get a notification, you'd get to know that your person went for a test, this person received their medication, the follow-up is so you are in the know as a person from the diaspora if you're part of this bond or voucher or whatever the pilot is doing. So it keeps you informed, so that your money that is going towards a specific cause is not going into partying or a Friday night out for a family who said they're struggling with cancer. So that is one of the things that I really, really liked. And of course, I know we'll have questions, and is this bond going to be taxed? What part of how much will that be taxed? How much taxation will be coming off that? So I guess we'll get to know more and more details. That's why these engagements are great. And I know, yes, the diaspora will have questions like Lambert said, trust, accountability. Those will be huge for us to know that, if we're putting money in here, is it actually going to the cancer bond or the cancer voucher? So we'll have questions like that. Is verification subjective? Those will be other questions maybe coming from the diaspora. Who gets this treatment? Is it somebody that, let's say, Brenda, I am sending money as a diaspora and I registered my person, maybe my sister or my brother, to be a recipient for this because they have a certain kind of cancer. Is it only that person? Is it going to benefit any other people who might be out there in Uganda and they're struggling with cancer? Would the funds in this pool be able to help other cancer patients out there? So those are some of the questions, but I agree. Another question would be, what if, the outcome does not happen? Dr. Catherine was talking about raising the $1 billion. What if we don't meet that goal? What does that mean for this pilot? So those are some of the things that I can think about, but I honestly appreciate you engaging us. And I'm so glad to see so many of my diaspora folks joining in this crucial conversation. Thank you so much, Vivian.
Thank you so much, Brenda. You are always a voice to reckon with. You share lots of insights that are helpful in really building a design that works for our people. With that, I also have one other member of the diaspora, and to make this, not focus on just North America, we invited someone who represents diaspora in the UK. He works on a lot of projects with the Ministry of Health in Uganda, though he's a UK diaspora. Moses Mulimira, if you're here, please share your perspective on why this is important to you.
Yes, thank you. Thank you, Vivian, for giving us an opportunity here in the UK. As you've shared, Moses Mulimira, I work closely with Uganda UK Alliance that links in with the Ministry of Health Uganda. Here in the UK, obviously, we are very excited by this opportunity to share some of our learning. Personally, I'm also a carer of someone who has been diagnosed with cancer. So it's a subject close to heart as well. But also, we are aware of the financial burdens that come up with the cancer diagnosis and also the late issues we have, people coming late. Here in the UK, we have set up associations. We have the doctors, nurses, and allied health, where some of our colleagues are looking at the area of workforce and mainly focusing on the skills and expertise, recognizing that most of our best trained doctors move out, but majority of them want to go back. So as part of this idea of financing, how can we ensure that we look in a company that allows us to move back home and offer some of our knowledge, expertise, and training and supporting of our colleagues, but also bringing back that knowledge to our systems here in the UK where we work, where some of our colleagues, some of our populations are also struggling, some of the challenges Uganda is tackling well. So for me, I'm interested and excited to see how we can mobilize the UK diaspora to join up with other diaspora colleagues. And I appreciate our embassy here who have given us a lot of platforms, and also the Ministry of Health. I've seen Dr. Charles Solaro is on here, who have been very supportive and encouraging us from the UK to come back home and share some of that knowledge, expertise, and international oriented experiences we've got to support some of our systems home. So yes, we are ready and we're happy to be involved in this. Thank you.
Oh, thank you so much for the work you do. And thank you for offering to partner with us for the UK diaspora. But also you mentioned Dr. Charles Solaro is here. If their doctor is here, please, let's have a moment to hear from him. He's from Ministry of Health. That's one of the key voices we need. Dr. Charles, are you still on? I'm looking through.
Oh yes, I'm still on.
Please.
A good evening. Yes, I've just been out listening. I think Jackson has really highlighted. First, I'm pushing on just actually it really talks the topic fighting women cancer, because every woman matters. I think this is just as we celebrate Women's Day tomorrow. I think Jackson has highlighted really the burden which we have under High Excellency, the Ambassador. And I think the issues which we need to work, that despite that government putting these resources, the outcomes are still not good because we are getting these patients late. So I think we need to drive both from the early aspect of early detection, but also aspect of how we get people into care early. So I think that's really where we need to open up. I think as Uganda, an African in nature, people have not yet got into the habit of wellness, early checks, and be able to identify so that we can be able to pick these cases early. So I think I am privileged. I also sit in the board of Uganda Cancer Institute, and we're looking forward to see how we drive this. We know the numbers, as has been highlighted, but the costs are quite high, quite enormous, and definitely they continue pushing people to poverty, and many of them are not able to access care in Kampala. That's why government is moving the regional cancer center so that we try to improve access. So looking forward to working with you. It's a great initiative, and we really need to be able to see that. The question which have been raised, I think we can work. Is the money going to be taxed? Will it be able to, I think let's put them in the platform. We can still continue to engage with the Ministry of Finance, colleagues, and seeing that how does this have a seamless financial flows for us to be able to support those who need this. Thank you.
Thank you so much, Dr. Alara. Dr. Alara is actually the Director General for Ministry of Health. So we are so honored to have you here with us because we know that Ministry of Health is fully present and is integrating some of these conversations in the work. So with that said, first of all, I would like to seek your permission to go beyond 1.5 hours because we're at 1 and 25 minutes, just to give us another half hour for those who can stay so that we really get the questions from the diaspora. And with that permission, I'm going to open it up so everybody who has spoken is able to answer all the questions, not all the questions, to answer questions that relate to their work. But the most important are questions for Chris to help us understand how this platform is going to work. What are the guardrails? How can we build trust? Not just for Uganda, but for everyone in another country, another continent who is thinking about, this idea. So we're open to all the questions. I'll start with the one that I think I see in the chat. It was directed toward Dr. Orem, but I'll kind of frame it in the context of this platform. It says, what are some of the measures being taken by UCI to make routine screenings accessible to normal people? I am assuming that means to the ordinary person who might not even be aware of cancer. How does this tie into the KPIs? And I'm trying to reframe it in the context of what we're doing today. And then Chris can build on to that.
So, okay, I kind of hear the question. I think what the UCI has done is to create a whole department which is concerned with community services. And within that department, there is an open clinic where people just walk in to do screening. And in addition to that, we also go into the community. We have a mobile system which goes into the community and then offer screening. But the most important aspect is not necessarily the availability of the test or the having the clinic, but knowledge. So awareness is very important. So we have been engaging with the media houses to first of all create awareness about cancer. And I'm glad to inform you that we have done this for over now 15 years. And we started with the level of awareness nationally less than 5%. And as I speak now, cancer awareness has gone up 17%. It's not yet what we want, but that means actually we are creating demand. And you can now direct people because they know about the situation. They can now go to kind of be tested. And I think that is also going to be an aspect of the downstaging that Catharine, together with Wil, were talking about. So already there's something being done. Yeah, thank you.
Thank you so much, Dr. Orem. And then Chris, to you, let's start with some of, you can build onto that, but also integrate the question that Brenda asked earlier. Who gets the treatment if there's a payment that has been made or a diaspora member has provided money for a treatment? Who else can get access to it? Is it one payment per one patient? Is it one payment into a pool? How does that work?
Good question. We are working on a defined service that is completed by a clinician. We start from there and want to understand exactly what goes into actually making sure that it is repetitive, that every clinician see that particular outcome the same way, and what goes into costing that outcome. It needs to stabilize. We're talking about cost. We need to understand what are the drivers behind the cost. over time. All right. That's based on patients who come in and they get serviced. And so we are able to understand that history. All right. Typically, I'm a diaspora person too. I use cash. I send cash when there are emergencies. There is a lot of uncertainty. I don't know how much is enough to be able to address the issue. I don't know how much is going to go into efficient care and how much will be absorbed by system friction. Even if the issue is resolved, it doesn't stop another emergency from coming up. So the system issue stays in place. So it starts with one family member. So we define that voucher for an individual because we want to be able to understand all these drivers, right? We are going to scale it around, but we start with one individual. The voucher is a defined service that needs to be completed by the individual who has been issued that voucher. Now, I would send cash. What we're doing is instead of sending cash, because we have understood the proof system, we know that it's stabilized, we know that there is a price band for, say, screening. There is going to be a menu of defined services on the platform with the ceiling price that you will pick. And once you actually, instead of sending the cash, you buy that voucher, the money will go into custody in Uganda. All right. The family member receives that voucher and takes it to an onboarded facility of the Uganda Cancer Institute, right? And redeems that voucher. Okay. And then once all the verification checks about eligibility, is it the right person? Okay. Is the price exactly fit? Does it fit the price range that we have actually understood for that particular key performance indicator? Then it becomes eligible. That's when the money leaves from the bank in order to pay the provider. So to answer Brenda's question again, no, it's designed for the person who the voucher was initially generated for. Now, you might say, if not all of that money is used, what happens? Well, it's basically the same thing. Like if you have your bank account and you use some money and you don't use the other, it stays in the account. You're getting the balance, you log onto the platform, you see the balance that is there. You can decide what to do with the rest. So that's how we handle that. I will also address the question around trust. We don't want to trust a bank. We don't want to trust a government. We don't want to trust a healthcare provider. We trust the rules. I am urging the diaspora to participate in writing the rules. So we have clinical activity that takes place. We need to convert that clinical activity into something that is payable. In between, we have rules. So we need to be able to write those rules that will enable us to have the trust that, okay, things are going to work. We have right of audit. It starts not only with how we basically write the rules around, clinical activity being become payable, which is will be done by the clinicians, but exactly, how the custodian services are set up, who approves the money to move out, what are the verification checks, all those gates that the money needs to move through before it gets released, the diaspora needs to participate. So we trust the rules, we don't trust an institution. That's the difference with this model. So I wanted to address that particular aspect. So it's about the rules that we actually put in place. So, and it's participatory.
Thank you so much for providing that response. And I'll try to merge some of the questions. Earlier, Dr. Olara mentioned and asked in abstract whether this money will be taxed. So in that context, you have also mentioned the bank, where the custodian bank. So which we usually refer to as the special purpose vehicle. So can you speak to how that will work if the money is released by the platform or through the platform, through the special purpose vehicle. How much of it gets to the service? Is it going to be taxed? And two, a question that I think we have talked about before, who is going to decide what the special purpose vehicle is going to be? And then another question that I'll leave out there is about the key performance indicators, like how, or the rules, who is going to be in charge of these rules? 3 questions.
Okay. With regard to tax, I'll give you an example. If I want to give a donation for healthcare, that money is already taxed. The money is already taxed. It cannot be, there's no double taxation here, except there are rules in the country that are taxing that money. To the best of my knowledge, if I want to be able to set up funds that I want to donate for healthcare, I pay the taxes and those funds go into an account. And then when I have the opportunity, I will release those funds. They're already being paid to the federal government. The tax is already paid. So if on the other side, there is need to pay taxes again, I am not aware of that. It's something we need to find out. So I will leave it at that. Now, when it comes to the question around the custodian bank, we know that the Ministry of Finance and the Bank of Uganda are much more knowledgeable on the qualities of the banks out there. What we will do is to participate in saying, hey, this is what we want of that bank. We give the requirements that we need for a special purpose vehicle / custodian bank. That's part of writing the rules. That's what we can do. Because we have, and the diaspora, we don't have oversight over the bank, but we have the power of writing the rules. We are providing the money, we participate in writing the rules. I'll give you another example. When we play a game, if you're playing football, you don't have to trust the referee. You don't have to trust the match officials. You don't even have to trust the field where you're playing. You trust the rules of the game. That's what motivates you to play the game. So we have the power to be able to write the rules. This is a huge deal. We need to participate in that. The questions that we have are basically answered through rules, which is what basically converts the clinical work into what becomes payable, which converts what the custodian bank needs to pay out once a clinical work has become payable to basically paying the provider, paying the pharmacy, and they have to be onboarded or accredited to the platform. So that's the second one. What was the third question?
No, I think you've covered them. If I did, then I've forgotten.
Okay.
We talked about the special purpose vehicle, and you've addressed that. I think that was one of the biggest, and it covers the trust elements. So if I remember, if we forgot anything, I will ask you again, but I think we covered it for now.
I just want to add one thing. I know Brenda talked about the bonds. That's you see, because we are working in phases, I said, okay, one stage must prove something that the next stage depends on. So the first stage is about voucher readiness. We have to do that. It's trust building. We write the rules, we execute the rule. It's repetitive. Over time, the prices begin to stabilize, and we see that everybody is seeing a particular key performance indicator the same way across cycles and across facilities and across clinicians. Once we do that, we stabilize our views around the key performance indicators. And also the Ministry of Finance begin to see exactly how the the price, the fluctuation in the prices begins to narrow, because some of the times the noise that goes into what we actually charge is because we are the process. I am perceiving one thing different from the other person. So once we become repetitive, it addresses that issue. So once we have built that trust layer in phase one, now we activate the vouchers. The vouchers are redeemed based on the trust building rules that we set in phase one. Now we create a history. It's a track record. A credit history is already something that we can use to underwrite a bond, a bank loan. That is done all the time. It's really nothing new. Okay. So once you decide that you want to participate in a bond in order to scale a particular service, it could be training of doctors with retention for a certain amount of time, or maybe it's about installing a PET-CT machine. All of these things, in order to be able to have community-wide impact, it requires more scrutiny there, because you have to go through certain regulations, and there is going to be some taxation, because it depends on the country, because of the securities laws in different countries. So there is no one brush to be able to handle this, but we would want to handle that once we get to that bridge. But I just want to lay that out. There is no single answer. It has to be looked at depending on where a potential investor wants to invest, to be able to see exactly what can we do in order to, number one, comply with the security laws in that country, and number two, to make sure that, okay, if there are any other additional risk like foreign exchange risk, how shall that be addressed? So I just wanted to add to that.
Absolutely. And speaking of investment, in the same context, if somebody wants, so first of all, if you could differentiate between what a voucher can be used to invest in versus what a bond can be used to invest in, that would be great. And then also the same rhythm of investment, how can non-diaspora invest in this platform? What are some of the different layers in which the non-diaspora can participate and invest? So, over to you, Chris.
Okay. All right. So the voucher is a gift. We normally actually send cash when you have a family member who says, oh, I have an emergency. It is cash that is sent. So instead of sending that cash, purchase a voucher. It's a donation, right? The reason why we do that is because it's going to allow us to generate a credit history. When you send that money, it's difficult to scale what has happened because it's not visible. When you convert that into a voucher, it is visible. It has a track record. We can be able to now scale that, right? So it is not a bond because it's just a donation. The voucher lays the groundwork for us to be able to now have access to broader capital that is like a bond. That becomes an investment.
Thank you. Maybe again, before I let you go, can you give us a better picture of, you've talked about the layers. We start with, building trust and then using the voucher system to build the trust, but also we have the layer of philanthropies, actually, which leads me to one of the questions that we've had from different people over and over again. Where is the starting capital coming from, and will diaspora, will the money for treatments go into operations or not? So, and while you're explaining that, if you could just give us a very high-level overview of what that pyramid is in a non-confusing, non-technical way.
Okay, so before I answer that, I think I forgot to talk about, I talked about a diaspora. We have global allies. They are faith-based organizations. They are people who, friends of Africa, they are in this. What they currently do is they might go into a bank and wire the money to take care of maybe training in one country or do something. They are in it. Instead of wiring that money, you buy a voucher, because that creates an opportunity for a multiplier effect, right? So the voucher, it's for not just for the diaspora, but for global partners as well. And when it comes to investing, yeah, it's also open to everyone, so it's not like it's only for the diaspora. Now, the trust building phase 1 requires what you call sunk cost, which means it's money which is specifically designed for system building. You have to build a system, you have to build a rail before the money flows on it. That's basically what it is. So we have to be able to have a system builder a philanthropist who actually lays that rail, that trust rail, those drafting of the rules. The diaspora leadership circle can come around, they sit there brainstorming, all these questions have to be converted into rules. Yeah, okay. So drafting the rules, and then also actually onboarding, the facilities that make up the Uganda Cancer Institute, they need onboarding, right? They need to understand this. They're writing the rules, but they also need to be able to really understand the rule. Consistency is the thing, and it requires an organization that has money assigned for uncertainty. That means they want to be able to lay the bridge for additional capital to come in. So once they actually spend this money, it becomes sunk cost, and that's when now the diaspora can come in with the vouchers. Let me call it the regular donations that we send. Instead of sending as really cash, it is buying vouchers that are defined for specific outcomes that have been studied over cycles and understood exactly what it takes to deliver that particular service, right? And so that's phase 2. Phase 3, we are actually building on that track record, which the vouchers have been able to allow us to understand, to go and say, hey, you have a broad pool of capital here, right? It's either bonds, it's bank loans, it may be even solar funds. We do have a credit history here. We can really show you the track record. Money is financially, money, there's this disciplined movement in the money, right? We have the results to show you. We can be able to really indicate exactly those who have benefited. And that is something to really, that credit profile, we are not expecting to have a credit score. In other words, that's our credit score, because someone is not going to lend you their money if they haven't determined your credit worthiness. And that voucher activity is what gives us the opportunity to thumb our chest and say, hey, see, this is what I've got. What can you give me? What else do you want me to provide to you? So that is how we get from trust building to activating vouchers to scaling using broader capital like bonds, solar funds, bank loans, right? And really bring in the broader economy where you can be able to have even contractors that want to maintain equipment and have been onboarded. They understand exactly how the system is working. They participate in it. They are contributing to economy. We make sure that those who need screening can be able to screen first, because we have actually expanded what we have proven in phase 1 and in phase 2.
Thank you so much. I know this is such a hot topic, and we are again running short on time, but I want to recognize the questions in the chat. Some are directed to the Uganda Cancer Institute. One is to deal with collaborations and partnerships in research, and another one to do with the workforce development. In terms of early detection, do you have simple technology, inexpensive for in-home use? And I will give an opportunity, a minute or so, to the director to answer those questions as Chris also thinks through how, to share how we are going to measure progress of this cancer financing platform, how to we're going to measure outcomes, how we're going to measure impact. So because it's impact-based. But Dr. Orem, if you'd like to have a minute to respond to those questions.
Yes, so about collaborations, yes, we are actively collaborating with many institutions from the US, for instance, and most of these are in research arena. And of course, about technology transfer, of course, we are also working on that. We have many initiatives, especially in the research on screening for cervical cancer, breast cancer. So those are there. So collaboration is very much welcome. Even with the UK universities, we also do have a number of them that we collaborate with, Cambridge, Oxford, and all those. So we do collaboration.
Thank you. Chris, over to you to just briefly mention, address that question.
So with regards to impact, we don't wait for 1 month, 2 months, 3 months to begin to see the impact, because we are able to observe that in real time, on a weekly basis, exactly what's going on, right? So, and because again, you can be able to see, we're using technology to make sure that you can see exactly what your money is doing. It doesn't matter the hour of the day, you can see exactly what it is doing. That is very motivating and very, very convincing. Number one, how it creates a multiplier effect. If you are a non-governmental organization, a foundation that has always been sending money, right? There are many pay-for-performance models out there. What makes this different is because we start by developing the proof layer first. We focus on generating the rules that enable us to show the proof. We don't ask for money and then answer questions later. We don't do that. That's the impact, because you can really see that in the enthusiasm on the uptake, because it is participatory and people are able to see exactly what the impact is. So if you can be able to say, all right, we need you, a family member to do a screening. Yeah, they have never done this before. We are not sending them cash because we know sending them cash is also a temptation. They might use some of the cash to do other things, because we have actually used that cash in order to buy a defined service voucher. They have to take that voucher to go and do the screening. You have invested in their own health security. And you are also happy. You're also, because you don't have to expect an additional emergency, because once you do that, and many more of us in the diaspora do that, the pool gets larger. Then we bring in broader capital. Then there is community-wide impact, because we can be able to scale that service. It is seen, the story is told not in periodically, but it's on an ongoing basis. That's what I'll talk about, the impact, if it helps.
Well, thank you. Thank you so much again, Chris. There are so many questions, we cannot exhaust them, but I'd like to encourage us all in the diaspora to please send in your questions or to put them in the chat. But also, if you are a diaspora leader, please, let's connect so that we can reach out to your constituents. And thanks to UNAA for giving us pledging that platform. I know that there are so many conventions to come. We are happy to talk to during conventions and even outside of conventions. And with that, we also have the Global Health Catalyst Summit coming up in September. So please visit the Global Health Catalyst Summit to learn more about some of these conversations going. But before I invite the ambassador to kind of say, give us her blessings, I'd like to invite the Wil to come back on and give us some concluding remarks. And of course, thanks to every one of us, everyone who has participated, both the speakers and the participants. But over to you, Wil.
Yeah, thank you so much, Vivian. It's been amazing. I mean, I feel like, um, talking about writing the rules, we need to have another dedicated session where just the diaspora talk about the rules that they want to see, to be able to get that trust and accountability and all of that. And first of all, just really acknowledging the work that has already been going on also with Uganda Cancer Institute. We visited that. It's just amazing, your leadership, Dr. Jackson. But you've been really working to write down these key performance indicators that are really going to be, like Chris mentioned, that can be converted into things that you can then pay through these vouchers. And I think that work, really want to appreciate what you've been doing there. Yeah, so there are a couple of thoughts are that, this is just the beginning of the conversation. I think these town halls, are really a great way to really engage and help, have the diaspora shape this whole platform. And so this is going to be the first one, but I think we need to have more where, we can have this additional engagement. And then the second thing I just want to say to end is really that, this is going to happen, right? So we want to be very clear that this is something that's going to happen. But I think what we want to do is make sure that it happens optimize that, like make sure that, it happens so that the impact is really truly high. And so why I say this, partly we're already planning to launch this in the summer in Uganda. So we want to make another trip. And so we know that, there's already conversations with ambassador, with the ministry, with Dr. Jackson and the government to plan that out. And I think that once that's locked in, we want to share that with these diaspora leaders, these wonderful diaspora leaders who are here today, so that we can really make sure that we coordinate that event. I think it's going to be a big event because we're going to join that together with the launch of a Lancet Oncology Commission on workforce development. It's going to create a lot of visibility, so it's really going to be an international event. And then secondly, we're going to come with investors who are going to be looking to implement the World Health Organization resolution that was passed last year on imaging, which kind of ties into the global cancer financing platform in being able to downstage cancer. So it's really going to be an amazing event, and I think we are really excited that this is going to start in Uganda. So really kind of appreciating all the people who are making this happen. Thank you.
Thank you so much, Dr. Wil. Again, I just wanted to, because once the ambassador speaks, nobody else will speak, but I wanted to thank everyone who has had a role to play. To our speakers, thank you, especially those in Uganda and time differences who are later than we are. Thanks for the sacrifice and for sharing your stories. To our diaspora, you are key stakeholders. Thank you for making the time to be here with us today. And we look forward to engaging more with you as we go along. It's just the beginning of the journey where you're stuck with us, or we're stuck with you for quite a while. And with that, I'd like to really invite, and to all the tech support behind the scenes and the Global Health Catalyst team, you are superb. We appreciate you all. But to crown this all, I'd like to invite the ambassador, if you're still on, to kindly share your closing remarks.
Thank you so much, Vivian, for being the voice and continuing to engage with us during these meetings in such a way that it is not an easy topic. It's not the challenge. Cancer it's a whole new conversation, and yet it's like Brenda shared. It has literally consumed our loved ones and our citizens. So to be able to be part of this conversation in such a way that to walk with a team like Dr. Orem, who's leading this exceptional organization, the Institute, the Center of Excellency, to have known and continue to discuss this subject in various ways with the various invitations that Dr. Will has extended over the years, the different universities, and also to just really have this opportunity to engage with the diaspora where you are part of the solution. This is a major commitment, and I know that all of us are going to continue on this journey. I would like to encourage the diaspora for us to have. I appreciate the invitation for extended for Denver, where we're going to hold the convention that's like the last weekend of summer, like Labor Day weekend. But I would really encourage us to see what other conversations can we begin to have as a follow-up to this, at least once a month, so that even by the time we have this launched in Uganda, we can have a virtual component of it, so that for those who won't be able to make it, but then we may have to have like a relaunch, because now our Ministry of Foreign Affairs has the return of the diaspora every December, So how do we also make sure that it carries those different corners of the diaspora, so that they're truly on board, and like you mentioned, we have the medical association. We have different associations. We have faith-based, we have students, we have all sorts of uh diaspora engagements. So how do we really truly begin to see that we open up this conversation, but more so have them to be actively involved. So thank you so much for your time, and really for committing to such a cause. Thank you.
Thank you all, and you feel free to stay behind, chat a little bit, but officially it's a wrap. Thank you, and we look forward to engaging with you more in the coming days and months and years. Thank you.